I have two bits of good news. The first is I don't intend to speak for 15 minutes, and the second is there are no slides. Thank you. I'll pay you later. Without sort of reiterating a lot of the things that Ian has mentioned, my life in surgery, in my involvement with CPOD, began in the early 1980s for the simple fact that Brendan Devlin was a consultant surgeon at North Tees Hospital, which for those of you who don't know it is Stockton. You don't really want to go there. Lovely place. And I was a senior registrar in general surgery in that place called the Northern Region. And in those days, consultants with a moderately forceful personality would encourage those of us in training to assist them in their endeavours, political or otherwise. I think that there was the possibility that your career progress might be inhibited if you didn't play along. In my case, it was a very simple suggestion that I was doomed to remain in the Northeast, because if I went to get a job elsewhere in England or somewhere else in the United Kingdom, the locals would not understand me and I wouldn't understand them. So I better behave myself in the Northeast, because that's where I was doomed to remain. But we did get involved locally in helping Brendan in sort of getting things off the ground, and by the time that the first CPOD reports where the data was being examined related to these patients, this was the sort of job for the senior registrar. And there's a really important lesson that I learned very early in those days when you were presented with the notes of a patient who had died about 3 weeks before, so you couldn't really remember who the patient was, and about half the results, of course, had never been filed, and if they were filed randomly in patients' notes. And usually, of course, patients who die may have had long hospital stays, and of course, so you had volume 1, volume 2, and volume 3, with the results randomly placed by very helpful house officers, F1s, in these various documents, and you had to learn to sift through this. So NCPOD was great. It made us organise hospital notes properly, because otherwise I had a bad job, so you know, life goes down the hill. But really, the important thing was I learned very quickly that it had to be written down, because if it wasn't written down, I couldn't find it. And that made my job next to impossible. I had to go to the X-ray department and find out, could I find the original X-ray folder that might have the report in there if I was lucky. And that was a really important lesson for those of us in the 1980s. And of course, it's still true nowadays of just about everything we do. If you didn't write it down, it didn't happen. And of course, writing it down nowadays means writing it down accurately and dating it and being quite clear about things. Still, if we look in hospital records, many patients are discussed at morbidity and mortality meetings, deaths and complication meetings in the United States. Still, there are hospitals that do not write down what the discussion was, what happened, and what action was taken. I think if Brendan were here and he knew that we were still doing that, as they say, he would turn over in his grave and he'd be back here giving us a hard time. It really just isn't good enough. Anyway, let's talk about some of the more recent things and the kind of lessons learned and the stuff that I perhaps learned by looking at some of the more recent audits that have involved surgical patients. And I thought I would just say a word or two about the two that have been published recently. The investigation that's called On the Right Course, that looked at cancer deaths in people under the age of 25 who die within 60 days of receiving some type of systemic therapy. You might say this is classical NCPOD type audit looking at patient deaths. What were the take-home messages from me? Now, many of you here I know will have read it, you'll have read it and you'll have a better understanding of it than I have. I was staggered to discover that no MDT existed for 1/3 of these patients. They had not been through an MDT. If you had told me that in the early part of the 21st century that cancer patients of any kind, age group or particular cancer diagnosis could get through a course of treatment involving multiple disciplines and many professionals, that 1/3 of them would not have appeared in MDT, I would have disbelieved you. I really would. I really did not think that that was the case. And I'm really quite staggered to discover that it should occur, particularly in this group. The second thing that bothered me about this was the discovery that less than 20% of these young people were involved in any type of clinical study or clinical trial. I, again, naively, in this particular context, thought that most people, young people, who were receiving multidisciplinary treatments for solid tumours and hematological malignancies would be included in clinical trials, because I was aware that there are large numbers of clinical trials available to these patients. The third bit that made for, I might say, rather worrying reading was the section related to what I call decision making, but which I think in the report is still described as consent. Sorry, I think that the use of that term is out of date nowadays. We shouldn't really talk about consent in the light of the Montgomery judgment. It's a minor error, but I do wish we could get away from it. Within that section, though, there were criticisms that patients didn't understand the intent of treatment. Was it meant to be curative? Was it meant to be palliative? There was very little information given to patients about the likelihood that they would be cured by the course of treatment that was being proposed, the risks of toxicity, the risks of death, or indeed discussions with patients and their families about the therapeutic ceiling that might be reached in the care of complex malignancies in children and young adults. Having said all of that, I actually found the document a highly educational read for me as a non-expert, someone who doesn't ever deal with these patients anymore. But I think that some of the particularly organizational aspects of care were highlighted by this. Much the same is true when I read the report on perioperative care of the diabetic patient. Again, there was criticism in the sense of room for improvement in at least 1/3 of patients, and once again, lack of continuity of care. Of course, maybe we can read that as being somewhat equivalent to failure to use an MDT in the context of the cancer patient. There was an interesting recommendation. It said that each hospital should have a clinical lead for the care of the diabetic patient who is intended to have surgery. I was immediately struck by my medical house job, where I did work on a diabetic firm, and there was one consultant, a man called John Alderson in Newcastle, who used to walk the hospital every day looking after all of the diabetic surgical patients. You kind of sort of wonder, where did it all go wrong? But I think it's a very worthwhile thing because, for one thing, it makes you very fit to have to work for someone like that, because you end up doing a ward round every evening that starts at about 4 and finishes at about 8, when you've wandered the hospital. And of course, to get around all of the patients requires at least 3 laps, because it takes you so long to do it that the patients have been moved while you're still doing that ward round. It did actually also make a few interesting remarks about cancelling. It said, avoid the cancellations of elective surgery. Yeah, great. Yeah, I'd go along with that were it not for the fact that just about every elective surgical patient, it seems to me, this winter is in danger of being cancelled at least once. The only good thing is you don't get cancelled on the day of your surgery, which is perhaps a bit more important for the diabetic patient. But still, it's a long way from perfect, and the report highlights that. Once again, for me, it was a highly educational read. It actually taught me stuff, and I think we sometimes forget when we read these reports. We're kind of wondering what would be the recommendations, what's the sort of bottom line. But actually, you can discover that there's an awful lot of factual stuff that you don't know. So let me finish with just a few words about one of the projects that's on the go at the moment, and that is the bowel obstruction study. This, of course, is looking at processes of care for patients who are diagnosed as having intestinal obstruction when they're admitted to hospital. The program will look at all aspects of clinical behaviour, everything from diagnosis and all the steps that might occur through to discharge, and the clinical decisions that are made at each step on the way in very traditional NCPOD style. But also, of course, we'll look at the organisational aspects. How do patients access such a service, all the way through to training of staff and arrangements at the time of discharge. It is a very important topic, of course. It's about 10% of all acute surgical admissions. About 3/4 of all the patients who present will have adhesions obstruction from previous surgery, and about half of those will actually need an operation. We have, of course, undertaken previous national audits. There was a national audit of small bowel obstruction that was published in 2017, which I think is interesting because it contains a lot of useful information that will inform us about whether or not people really take notice of national audits when we repeat work, and we see whether or not the first piece of work has had any great impact. About 5–6% of patients who come to hospital with bowel obstruction will die. If you present with large bowel obstruction as an acute case, then you have about a 10% chance of dying. That's what the previous studies have shown. It'll be interesting to see whether or not many of the risk factors that were identified in those earlier studies have been addressed, and whether or not that will make much of a difference. And I think that's probably the thing that makes me think mostly about the challenges for the future and where this type of program goes. We identify clinical failings within our system. That is diagnostic tests of dubious value that still get used, therapeutic interventions, particularly of a surgical nature, that are perhaps of limited value or perhaps not used in the correct way. And yet the amount of clinical research, and I'm not talking here just about trials of efficacy, I'm talking about our ability to look for prognostic factors, our ability to look at new diagnostic processes. We don't really, I think, in this country, make best use of the information that is generated by these reports to inspire us to do more clinical research to get better answers to the clinical issues. And I think that still is a problem that we need to address and do better with. The second bit is, though I think even more important, and that is the reports consistently describe defects in the organisation of surgical care and the pathway that the patient has to make their way through in terms of what is nowadays, of course, involving many professional people across a wide range of disciplines to provide optimal care. And whether we like it or not, I do not believe that we can continue to try and deliver surgical care using these fairly complex pathways, even for what you might consider to be a fairly straightforward condition like bowel obstruction. I don't think that we can deliver optimal care using the current system that we do. We cannot create the resources in every hospital that currently provides surgical care to provide high quality care in the way that we do. Our surgical jam, I'm afraid, is spread too thinly, and we need to wake up to that. And I think that these reports consistently tell us that we cannot achieve optimal surgical results with this type of organisation. And I think the onus falls upon us as professionals to shape that change in the organisation so that we do genuinely get better results in the future. I'll make a prediction, therefore, about the outcome of the study on bowel obstruction. It will show us that there are just too many failings in the pathway that provides patient care in many of the hospitals to which patients are admitted. On that salutary note, I've said enough. Thank you very much indeed.